The next speaker is Dr. Inder Anand from the Medical Center, University of Minesota. The trial is the title ANTHEM-HF, a heart failure trial also. Autonomic regulation therapy for the improvement of left ventricular function and heart failure symptoms.
Thank you, Mr. Chairman, ladies and gentlemen. This is my title slide with my disclosure on it. And by way of a background, I think all of you are aware that in heart failure there is an autonomic imbalance which is characterized by increased sympathetic activity and withdrawal for parasympathetic tone. And this is associated with progression of heart failure and worse outcomes. A number of recent preclinical and one clinical study has suggested that electrical stimulation of the right vagus nerve may restore autonomic balance. However, left-sided vagal nerve stimulation, which could well be combined with the cardiac devices like ICD and CRT, has never been evaluated in heart failure, and the effect of right and left-sided vagal nerve stimulation has never been directly compared. So the objective of our study was to evaluate a new autonomic regulation therapy, we call it ART, with left or right-sided vagal nerve stimulation in the treatment of chronic symptomatic heart failure with the reduced ejection fraction. 60 patients were randomized with heart failure with reduced ejection fraction less than 40%, NYHA class 2 to 3, who were on excellent optimal medical therapy. Patients were randomized either to the left or the right side stimulation. The device was implanted. 2 weeks later, the device was activated, and over the next 10 weeks, the stimulation parameters were progressively and carefully up-titrated. At the end of 10 weeks, when the titration was complete, all the patients went through cyclic vagal nerve stimulation therapy for the next 6 months. And during this period, at 3 and 6 month outcome measurements were made, and throughout the period of the study, which is 9 months, safety and adverse events were collected. We used the Cyberonics VNS therapy system. If you recall, Cyberonics is the company that first invented this system and has been used in patients with epilepsy. Over 100,000 such implants have been made for the last 25 years. In our case, they were implanted either in the left or right side of the vagus by surgeons, and we did not use an RV sensing lead. Chronic intermittent stimulation of the vagus nerve was carried out at 10 hertz, as you see here, using the natural frequency, which is the frequency at which the vagal nerve usually discharges. Here is a schematic of it, 10 hertz at 250 millisecond pulse width. Each cycle lasted 10 seconds on and 40 seconds off. The intensity of the stimulation was titrated, as I said before, over 10 weeks to a maximum tolerable current below the threshold of any side effects or increase in heart rate. We were very careful in monitoring these people continuously with an EKG to confirm that no acute heart rate changes actually occurred. Over time, the side effect profile gradually increased, the threshold for it increased, and we were able to give an average of about 2 milliamp threshold stimulation in these patients. Here are the primary safety outcomes, and you see there were a total of 21 serious adverse effect. Only one of them was related, and this was an embolic stroke that occurred during surgery. The 20 other was unrelated, and you see they are equally distributed between the left and the right side. The commonest non-related, non-serious side effects was voice alteration, hoarseness, cough, oropharyngeal pain, equally distributed between the two-sided study. And these are actually very similar to what has been seen in the epilepsy population. There were no implant-related infection, system malformation, and none of the patients or their PIs requested the therapy to be either temporarily or permanently terminated, suggesting that the procedure as well as the therapy was well tolerated by these patients. Here are the primary and the secondary efficacy endpoint. The primary endpoint of ejection fraction on a whole was increased by 4.5%, very similar on the left and the right side. The decrease in left ventricular and systolic volume was not significant, but it was very similar on the left and the right side. The secondary endpoint, there was significant reduction in the left ventricular and systolic diameter. The NYHA class improved in 70% of the patients by at least one class, and none of the patients worsened. 6 minutes walk increased by 56 meters. Minesota living with heart failure quality of life scores improved by 18 points. Heart rate variability increased by 17 over the duration of the study. At the end of the study, between the baseline and the last reading, there was about a 4 beats per minute decrease in heart rate. Anti-pro-BNP did not change, but high sensitivity CRP decreased by nearly 0.5 milligrams per liter. So we'd like to conclude that the ANTHEM approach to ART of using a chronic, low amplitude, natural frequency, and the frequency of the vagal nerve at 10 hertz on either left or right side was feasible and well tolerated. The safety assessment did not raise much concerns. Both left and right-sided ART was associated with improvement in cardiac function in LVEF and systolic diameter and heart rate variability, and most of the subjective measures of heart failure symptoms. We believe that these are encouraging observations, and further investigation of heart and control clinical study is therefore warranted. Thank you.
Thank you very much, Dr. Anand. This is another concept of treatment of patients with heart failure. Questions, please? Great, a lot. Please, let's start from this gentleman. Please identify names and origin.
Thank you. Steve Stiles, theheart.org. Dr. Anand, this is envisioned as a lifelong therapy for these patients, is that correct? And with greater time that the patients have the therapy, are there signs of nerve fatigue? Is there an expectation that they might be weaned off it at some time if they improve clinically? Can you tell us something about the long-term aspects of this treatment?
Both very good questions. Firstly, all the therapies we ever use in heart failure are really for lifelong, whether it are beta blockers, ACE inhibitors, CRT therapy. We haven't ever tried to wean them off those things. There are the only example might be LVADs, where you might want to wean them off. So I think the answer to your question is yes, we'd probably be a lifelong thing. Your second question is even more interesting. Is there a fatigue of the vagal nerve? Not that we know of. In the animal studies going on for years, there doesn't seem to be anything associated with this question of fatigue.
So animal work is
the animal
part of
work
the basis
supports it.
of the rationale for it being a long-term therapy.
That is correct. And as you know, there is very little human work. There were the 32 patients in the first study. We heard of 90-odd patients yesterday and 60 here. We really need to do a lot of work before it is ready for prime time.
Ben Herschler from Reuters. I wonder if you can comment about the contrast between this study and Nectar, which obviously didn't succeed. That was a controlled study. Yours wasn't. Is that part of the explanation? Or was the increased pulse that you used in this study the explanation? And also, Could you comment on the 4.5% increase, how clinically significant that is?
Right, of course. Both very interesting questions again. I think you raise an important question about the use of sham operation or active operation, not leaving them to be stimulated. But as you saw yesterday, even that was not able to overcome the bias that might be there of the placebo effect. I would entirely agree that all the subjective elements can be easily explained on bias, on placebo effect. But I think they did not see even a slightest difference in the more objective parameters. And I would say that the ones that they measured, of course, were remodeling parameters as well as the heart rate variability parameters. And I think that would be the only way I would want to go any further. I wouldn't like to go any further with that, but just to say, yes, there were objective measures that did not improve. Subjective did improve. In the same way, in our case, there were objective that improved, and the subjective that improved may well be related to a placebo effect. We really can't negate that.
And the 4.5%, how?
Yeah, I think that's I think over a period of 6 months, it's a very impressive increase.
Am I correct in thinking that for the primary endpoint, you pooled the left and right side? And did you compare the left and right side at all?
Yes, we did. And unfortunately, in the 7 slides that I have, I wouldn't be able to do that. It would be in the main paper, in the Journal of Cardiac Failure. We show all that precisely.
And what was your finding?
No significant change. But remember, we are looking at 60 patients. The confidence intervals are so wide when we compare right and left. So, if you had 500 patients, will there be a change? I cannot say. It is possible.
Where does this leave you with deciding whether you should use the left or right?
Well, you know, I try to introduce the fact that on the left side, you have the great advantage of going straight into where we implant all the devices. On the right side, you can do it. You have to have a little awkward way of crossing over and so on. We believe if this technology pans out and is beneficial, it will be introduced into devices very easily. And that's the advantage of going into the left side. And remember, all the work of the epilepsy group, of depression patients, over 100,000, as I mentioned, have been on the left side.